Hello everyone and welcome back to the MedMax channel. If this video reached 10 likes, I will upload a complete PDF summary containing every ventricular rhythm we discussed today, fully structured and illustrated with ECG examples. This lesson took significant time to prepare because ventricular dysrhythmia require precise visual interpretation. I include many ECG images to help you understand how this life-threatening rhythm actually look in real clinical practice. And at the end of this lesson, I will reveal the correct answer to last episode's very difficult NCLEX question, along with the detailed explanation. So, let's begin. Ventricular dysrhythmias. These are the most serious rhythm in cardiology, because they originate below the AV node, in the ventricular myocardium or the His-Purkinje system. Whenever electricity is spread abnormally through the ventricles, the QRS complexes become wide and bizarre, and the rhythm can quickly become lethal. Let's start with getaway rhythm of the ventricles. PVC, premature ventricular contraction. PVC are early beat coming from a ventricular focus. They produce wide, tall or bizarre QRS complexes because they bypass the normal His-Purkinje conduction system. PVC common causes is low potassium, low magnesium, ischemia or myocardial infarction, hypoxia, stimulants like caffeine, drugs, and digoxin toxicity. If we're talking about danger, occasionally PVC are benign, but frequent PVC may progress into ventricular tachycardia, which can lead to ventricular fibrillation. Let's discuss high-risk premature ventricular contraction patterns. First, BIGEMINY. It means every other beat is PVC. Second is TRIGEMINY. Every, of course, third beat is PVC. Number 3 is COUPLETS, which means is 2 PVC back to back. Number 4, multiform PVC. Different shapes, multiple foci, more dangerous. And last one, R-on-T phenomenon. PVC falls on the T waves, which can trigger ventricular fibrillation. PVC management include correct potassium and magnesium, treat ischemia or hypoxia, avoid stimulants, and beta blockers for symptomatic patients. So, let's jump to the next problem, which is a ventricular tachycardia or V-Tach. Fast, wide complexes rhythm originated in the ventricles. Their rate is between 140 and 250 beats per minute. Think of V-Tach is midpoint between premature ventricular contraction irritability and full cardiac arrest in ventricular fibrillation. It is one of the most important rhythms. V-Tach divided for 3 groups. V-Tach with pulses, which means stable, the patient is awake, blood pressure maintained, symptoms are mild or absent. In these cases, management require amiodarone, procainamide, sotalol. If medication fail, synchronized cardioversion. The next is V-Tach with pulse but unstable. Signs include hypotension, chest pain, alterated mental status, sign of shock. In this case, management is immediate synchronized cardioversion. This is time sensitive. And third group is Pulseless V-Tach. Is treated exactly like ventricular fibrillation. There is no pulse, no perfusion, no cardiac output. In this case, management include defibrillation, which is unsynchronized shock, cardiopulmonary resuscitation, epinephrine every 3 to 5 minutes, and amiodarone. This is a shockable rhythm. So, it was group of V-Tach. Let's talk about type of ventricular tachycardia. We have monomorphic V-Tach, which look like all QRS complexes look the same, usually regular rhythm, often due to scar tissue, previous myocardial infarction, or structural heart disease. A single ventricular focus fire rapidly. Next is the polymorphic V-Tach. The QRS complexes change shape, size and direction. This is a much more unstable and dangerous. The most famous subtype is Torsades de Pointes, a special form of polymorphic V-Tach, where the QRS complexes appear to twist around the baseline. Primary causes is low magnesium. Secondary causes, prolonged QT interval due to antiarrhythmics, antipsychotics, haloperidol, ziprasidone, also macrolides like erythromycin, fluoroquinolones, hydroxychloroquine, methadone, and hypokalemia. Torsades de Pointes is a danger condition which can lead to rapid progression to ventricular fibrillation and sudden cardiac death. We can manage it with IV magnesium sulfate, stop QT prolonging drugs, correct potassium, and, if unstable, defibrillation. We're also supposed to know some condition of V-Tach, like sustained and not sustained. Sustained ventricular tachycardia lasting more or equal 30 seconds or hemodynamic instability. Sustained V-Tach usually requires intervention like amiodarone, cardioversion, and ablation. It also has high risk of progression to ventricular fibrillation, often associated with ischemia, scar tissue, structural disease. ECG findings often include capture beats, abnormal sinus beats breakthrough, fusion beats, which is a hybrid sinus plus ventricular beat, and IV dissociation, which means the atrial and ventricles beat independently. These confirm ventricular origin. Next, not sustained ventricular tachycardia, lasting less than 30 seconds and stopping spontaneously. Key facts, often asymptomatic, sometimes found only on Holter, caused by PVC runs, stress, stimulants, hypoxia. Not sustained is less dangerous, but still requires evaluation. Alright, next ventricular problem is ventricular fibrillation or VFib. This is chaotic, disorganized electrical activity with no meaningful contractions. There is no pulse, no blood pressure, and no cardiac output. The ECG look like irregular scribbles. V-Fib management require immediate defibrillation, followed by cardiopulmonary resuscitation, epinephrine, amiodarone. V-Fib is a shock first rhythm, every second count. The next we discuss asystole and pulseless electrical activity. Asystole is an actual flat line, no electrical activity, not a shockable rhythm. In this case, management include CPR, epinephrine, correct reversible causes. There is important point: never defibrillate asystole, because there is no electrical activity to capture. And finally, pulseless electrical activity, which actually means electrical activity on the ECG without a pulse. The heart shows electrical impulses, but no mechanical contraction. Common causes is hypovolemia, hypoxia, hypothermia, hyperkalemia, cardiac tamponade, tension pneumothorax, and thrombosis, like a myocardial infarction or pulmonary embolism. Treatment is the same as for asystole, CPR, epinephrine, and treat underlying cause. And once again, pulseless electrical activity is not a shockable rhythm. Alright, let's do some recap. If we're talking about hierarchy of ventricular danger, least dangerous, occasional premature ventricular contraction. Moderately dangerous is frequent PVC, COUPLETS, multiform PVCs. Dangerous, ventricular tachycardia with pulse and torsades. And of course, immediately lethal, pulseless ventricular tachycardia, ventricular fibrillation, asystole, and pulseless electrical activity. There is a lot of information, but I recommend to start with small pieces. How to recognize ventricular rhythm quickly. White QRS, think ventricular origin, or PVC, V-Tach, Torsades, or V-Fib. If we're talking about shockable rhythm, think ventricular fibrillation and pulseless ventricular tachycardia. And keep in mind, we never shock asystole and pulseless electrical activity. If summarize everything to small cheat sheet, first, pulseless V-Tach or V-Fib, treat with defibrillation. Second, V-Tach with pulse and unstable, synchronized cardioversion. 3. V-Tach with pulse but stable, amiodarone. Number 4, Torsades, IV magnesium. And number 5, asystole or pulseless electrical activity, treat with CPR plus epinephrine. Alright, let's jump to explanation for very hard question which been in previous video. A 72 years old patient develops a narrow complexes tachycardia at 190 beats per minute. The rhythm is irregular and P wave are not visible. Blood pressure is stable. What is the most appropriate initial action? And right answer is C. Perform vagal maneuvers. And here's why. The rhythm is regular, narrow QRS, P wave not visible, hemodynamically stable. Sounds like symptoms paroxysmal supraventricular tachycardia or atrioventricular nodal range-bound tachycardia. The symptoms also sounds like atrial fibrillation, but AFib is always irregular. In our cases, the rhythm is regular. Because the patient is stable, the first line treatment is vagal maneuvers. If that fails, adenosine, if unstable, cardioversion. This scenario is one of the most testable situation on NCLEX. Alright, let's do one more questions and I give you explanation in the next video. Actually, you can do it now in the comment. Your version in the comment. A 60 years old patient with a history of ischemic cardiomyopathy and prior myocardial infarction is admitted to emergency department for dizziness and palpitations. ECG shows a wide complexes tachycardia at 180 beats per minute. The rhythm is regular, QRS complexes are uniform in shape, and P wave are not associated with the QRS complexes. Vital signs: blood pressure 82/50, heart rate is 180 beats per minute, oxygen saturation 94% on room air, patient is confused and diaphoretic. Which of the following is the most appropriate immediate intervention? Take your time and give your guess in the comment. And once again, if this video reaches 10 likes, I will upload the complete PDF with all ventricular rhythms fully illustrated. If you found this video helpful, please give it a like, subscribe to the channel and share it with someone studying cardiology or preparing for exam. This is MedMax channel. Medicine made simple.